Yeah, so usually we start with kind of an overview of distinguishing different types of spells, especially what's epileptic and what's not. My presentation is about things that happen during the night, which is a particular challenge within that group. So that's basically what I'm going to be talking about. By way of disclosures, I don't have any relevant for this, except I will mention some off-label use of medications. My main disclosure, Dr. Holmes already told you, is that I'm both a sleep specialist and an epilepsy specialist. I do have some audience response, so if you don't have it on your phone, please scan the QR code, because I think especially, I find it especially fun for this sort of a presentation, because I'm going to be showing you some cases and some videos, and hopefully get some opinions about what's going on with those people. So I'll give you a second to do that. When I did this, it took me longer than I thought because it didn't show up. Okay, hopefully most of you got it. All right, so within spells, what's particularly difficult about things that happen at night? Well, it's pretty obvious. The patient is less likely to recall the onset, at least. They're probably sleeping. They may recall absolutely nothing. Things like, I can't explain why I woke up and the challah was in the freezer. One of the patients actually told me that. And then I'm trying to figure out what had happened. And there may or may not be witnesses. If there are, they may miss the onset, or they may miss the entire episode. So the information that you're getting is incomplete, probably at best, and sometimes basically non-existent. When you talk about seizures, nocturnal seizures tend to happen randomly during non-REM sleep. And that's helpful to some extent, as you'll see when we talk about some parasomnias. I'm not going to go into detail about specific syndromes, but we all know there are some that occur mainly or exclusively during sleep, such as benign Rolandic epilepsy, autosomal dominant frontal lobe epilepsy, juvenile myoclonic, and Landau-Kleffner. Parasomnias, many of you are probably less familiar with, because as neurologists, we get comparatively little training in sleep medicine. At least if you do a general neurology residency. So parasomnias are abnormal behaviors that are associated with sleep phenomenon. Usually we think about them happening during sleep, but not all of them. Some are behaviors that happen while the patient's awake. Cataplexy is an example. Sleep paralysis is an example. The patient has woken up and they're paralyzed. But there are a number of awake behaviors that happen during sleep, such as somnambulism, sleepwalking, sleep talking, or sleep abnormalities such as sleep terrors, REM behavior disorder. And when somebody comes to you in the clinic and they're describing these to you, the differential can be challenging. So various types of parasomnias. There is normal motor activity that could be confused with something else. A patient just describes myoclonic jerks, and that can be just hypnic. And that can be, and you can also have a little bit of normal jerking during REM sleep. Those things can be normal, but they may come to your attention. Arousal disorders are very common. Sleep drunkenness has probably happened to many of you. If you get woken from deep sleep by a page or whatever, you may initially not really remember what's going on. Some people slur. That's actually a normal phenomenon. There are movement disorders that are associated with sleep, mainly restless leg syndrome. And then I'll be talking about non-REM parasomnias, the ones that happen in non-REM sleep, and REM parasomnias. Okay, so I'm going to start with a case, and you'll be able to vote when I go to the next slide, whether you think this patient has epilepsy. So this is what you got, and this is an actual patient of mine. 26-year-old man who had a 4-year history of walking about at night, apparently confused, no memory of the events. He's found himself sleeping downstairs, not remembering how he got there, observed walking about quietly. Family was always able to encourage him to get back to bed. Never any tongue biting or incontinence, never had any episodes while he was awake. And in terms of other history, he has had multiple concussions due to football and snowboarding, but no loss of consciousness described with those, and he works as a firefighter. So, do you think he has epilepsy? Yes or no? Let's see what people think. And this isn't entirely fair, but sometimes this is the starting point in your clinic. I'll give you all a second, but okay, so it looks like most of you don't think he has epilepsy. But some of you do, and many say maybe, which I think with that history, that's probably the most appropriate, but I'll give you more information as we go. But this is just to illustrate, the uncertainty of your starting point with a lot of these patients. Okay, now, okay, so this is a case that I actually saw, a 32-year-old who's described to have convulsive seizures after an automobile accident, and I think it already happened. This is very quick. Let me go back if I can. Okay, so watch the video. I think this takes a second. Sorry, we're having lots of technical difficulties. How do I advance it? There, okay. Yeah, just watch what she's doing. She was referred for generalized convulsions happening asleep and awake. That was it. So, the description is convulsive. So that obviously was extremely misleading. I've never seen another patient like that, but that's an extreme of what can happen. The description you get is convulsion. You look at it, it's clearly a hypnic jerk. Okay, so talk a little bit about normal motor activity when you're asleep. There's postural shifting that may seem abnormal to people. This may be restricted in Parkinson's disease, so people can't move around as much. That can also sometimes be problematic for their sleep. Paralysis normally happens during REM sleep. Pretty much everyone has had some experience of this. If you've ever had the common dream where you're trying to run and you feel frozen, that's probably because you have some awareness that you actually are frozen. As I described, you can have myoclonus and hypnic jerks occurring during sleep, which are normal. So sleep starts in myoclonus. This is just sudden jerking movements, usually of the limbs, usually when falling asleep. This is pretty much always benign. There are things that make it more likely to happen, such as any kind of stimulant. Rarely, this could be confused with epileptic myoclonus, which is the case I just described, but usually by history, this is pretty clear. Occasionally, I've seen patients where this is so disruptive, they're trying to fall asleep, and they're just jerking, and you actually have to treat it. It's very unusual, but you could use a low dose of clonazepam if that happened. Now, some movement disorders, I'm not going to go into detail about all of these, that occur during sleep. Bruxism is, teeth grinding. This is very common. It's sometimes more of a dental problem, but it can disrupt people's sleep. Nocturnal leg cramps can be very disruptive. I'm going to talk a little bit about the other things: arrhythmic movement disorder, restless legs, and periodic limb movements. This is a 2-year-old boy who was in the hospital for other reasons, for video EEG monitoring. But this is what he did during his sleep, and he actually is asleep. You can see on the graph there, if I can get, there it is. You can see now I can't see oops. You can't see the cursor. Well, it's always something. But on the top, that's actually a hypnogram. So the black lines are EEG, and this patient's asleep. You can actually see some sleep, because it's compressed, it's polysomnogram. Those are slow eye movements, so this kid is actually asleep during it, and then you see the movement artifact every time he moves. So this is not epileptic. It doesn't need to be treated. It's called rhythmic movement disorder. Certainly all pediatric people know about this. It's often seen in drowsiness and persists into light sleep. It is more common in men for reasons that aren't, in boys rather, for reasons we don't really understand. Most patients don't require treatment except safety. I mean, this kid fortunately had a very thick wrap on his head, so he wasn't hurting himself, but that's what you have to do. And again, a rare exception, this can persist into adulthood. And in a kid, it's not a big deal. If you've got a bed partner, that can be very disruptive if it's happening all the time. So you can treat it if needed with either benzodiazepines or tricyclics. But that's unusual. Much more common is restless leg syndrome. This consists of disagreeable leg sensations, typically occurring when sedentary, sitting still, and resulting in an almost irresistible urge to move. So the patient's aware of the symptoms, but they may be overlooked, and you have to ask specifically about what they feel. Or they may say itching, they may say pain, they may say it feels like ants on their legs. As I said, it can occur at rest, but the main problem is usually and the patient's trying to get to sleep, and they get this very uncomfortable sensation. They often come in just telling you they can't get to sleep, and they have insomnia. They tried all these insomnia treatments, but if you don't ask, you may not get that. And then related to that is periodic limb movements, and the videos show these. These are often relatively subtle. The videos here are a little bit more than what many people do. The one on the top there is more of kind of a whole body shifting, but still pretty subtle. And the patient's often completely unaware of these. Because they're often subtle, the bed partner may be unaware. Many, but not all of these people also have restless leg syndrome, so that can be helpful in trying to figure out what's going on. This may be clinically insignificant, can result in frequent arousals, which is a problem, but also rarely could be confused with seizures. You know, you get the description that there's this violent kicking when somebody's asleep, and getting careful history, you may be able to figure out that it's a periodic movement, but not always. And this is an illustration. Again, this is a hypnogram. So so it's a little different than those of you who are looking at EEGs. The top is the EEG. Again, it's compressed. And what the orange boxes show you is actually electrographic arousal. And then the green is EMG. So those are when the leg movements happen. So this is somebody who's having repetitive leg movements, in this case about every 30 seconds, most of which with arousal. So that can be disruptive. It can be associated with other conditions, pregnancy, iron deficiency. You have to think about all these things. If it's an underlying condition, the best treatment is to treat that condition. It can also be associated with various medications, mainly stimulants. How do you treat it? Well, you can use symptomatic treatments, and you don't necessarily have to give medication for this. Massage or bath before going to bed. We sometimes recommend weighted blanket. There are compression devices that can massage legs as they're going to sleep. You can use iron supplements, particularly if the ferritin is low. And the usual cutoff for labs being low is sometimes as low as 15, but we tend to treat anything under 75, which will come back as completely normal if you just get a ferritin test. Some anticonvulsants, in terms of treatment, the first line is now gabapentin or pregabalin, or the long-acting form, which is actually approved for restless legs. The others are not, is the gabapentin and anacarbil, which is a long-acting form. It's a prodrug of gabapentin. You can use dopamine agonists, but these are not considered first line, mainly due to augmentation. Patients who take these, it may work initially, but then it gets worse, and you start escalating the dose, and they get worse and worse. The only thing you can do is take them off completely and get them onto something else. If those don't work, you can use benzodiazepine or opiates, although, for obvious reasons, we tend to avoid those. Okay, so this is another case where I'm going to ask you to vote after the video, what you think this person has.
No, it's right! No! What are you doing, Rod?
Okay. So what do you think this patient has? Frontal lobe epilepsy, confusional arousal, a sleep terror, temporal lobe epilepsy, and REM behavior disorder. And again, these isn't entirely fair, but we have the advantage of seeing the video. Actually, now people will sometimes come in with a video, so that can be helpful. But without having more history, you may not be able to figure it out. So it looks like there's a split here. Some people think this is confusional arousal or sleep terror is about a third each. Could be frontal lobe epilepsy or REM behavior disorder. So this is actually an arousal disorder. He has a sleep terror, and we'll go through the different arousal disorders so I can go back and tell you why that looks like one. So there are confusional arousals, which I mentioned. This is just an arousal from deep sleep, usually transient, doesn't necessarily need to be treated. There are various forms of sleepwalking. So these are automatic behaviors that happen during non-REM sleep, usually N3 or deep sleep. Somnambulism, which is sleepwalking, and one of my favorite terms in all of neurology. Well, somniloquy is actually my favorite. That's sleep talking. But you can also get eating in your sleep or what's called sexsomnia. So these are all automatic behaviors that people can do when they're sort of partly aroused from deep sleep. Sleep terrors are a little different. They do happen in non-REM sleep, but they're usually associated with screaming, sudden arousal, and then they go back to bed. This is an all-night hypnogram. I apologize, I keep forgetting the pointer doesn't work. So this is a graph of a normal night's sleep, which most of you are probably familiar with, but on the left you can see W, which is awake, then R, which is REM, and then 1, 2, 3 are deepening stages of non-REM sleep. So that's kind of a normal progression, that you pretty quickly go into deep sleep, or N3, and then about 90 minutes you go into REM. And then that pattern repeats itself overnight, where if you look at the big picture, you get most of your N3 or deep sleep early in the night, you get more of your REM sleep late in the night. That can be helpful. Whatever's going on, if it always happens half an hour after they fall asleep, that makes it more likely to be a non-REM parasomnia. It doesn't tell you what it is, but it would be rare to have REM that quickly. And if you've got nocturnal seizures, it should be more random. You won't always have it happening, shortly after people fall asleep. What exacerbates any of these? They tend to happen more in young people. That's pretty much all of them. Sleep terrors, sleepwalking, talking, all those things happen more in children than in adults. They can be exacerbated by hypnotics. This is one of the reasons that we don't like zolpidem or benzodiazepines in sleep medicine for insomnia, because it can induce some of these behaviors. It can happen if somebody's sleep deprived with rebound, because they get more deep sleep, and so it tends to happen then. Anything that disrupts your sleep can result in sleep disruption and an increase in those. So it could be secondarily due to another sleep problem like sleep apnea. So how do you treat these? Usually it's addressing the exacerbating factors. A lot of these patients are sleep deprived or they have other sleep problems. If you address that, it will usually get better and doesn't require treatment. But you can, if you need it, use low-dose clonazepam or clonidine. Okay, so this is going to be another one. It is actually running. So this is a 33-year-old man who has repetitive shaking in sleep, happens multiple times nightly. And this is what it looks like. So based on the video, do you think he more likely has frontal lobe epilepsy? You'll be able to vote in a second. Frontal lobe epilepsy, confusional arousal, sleep terror, temporal lobe epilepsy, or REM behavior disorder. I think that's all. Yeah, that's pretty much it. Actually, the video goes on. He has a similar one, like shortly thereafter. So let's see what people think of that one. Yeah, I think the key here is that they're repetitive, they happen, and they're very stereotyped. And if you just look at the movements, you might confuse it with one of these other things, but most of you answered correctly that this is a patient with frontal lobe epilepsy. And it's partly by video, but of course, this isn't entirely fair, because in this case, we had the EEG, we had the history, and this guy actually had refractory epilepsy since age 4. And he previously had epilepsy surgery, failed VNS, so he had very refractory seizures, up to 12 per night. And this is actually what his EEG looked like. And so this is EEG. You're probably more used to looking at it, but in case you can't see the actual montage, so this is a longitudinal bipolar, left over right, and the frontal is in the top two chains. So basically, as with many of these people, you really don't see anything except artifact when they happen. This can be a relatively restricted focus, and you've got all this art movement during it. So the EEG doesn't always help you. What really helps you is seeing the video and seeing that it's very stereotyped. And that's just the end of his seizure. This is his MRI. So we know he's got a lesion in the frontal lobe that's most likely associated with this seizure. Okay, so how do you tell nocturnal seizure versus parasomnia? As I mentioned at the beginning, these are both frequently unobserved or partly observed. If they occur randomly during the night, they're more likely to be a seizure. Now, that's not entirely true. Seizures tend to not happen at all in REM sleep. So overall, there may be more toward the early in the night, but seizures will generally happen at all times of night, whereas a non-REM parasomnia would usually be preferentially earlier in the night, and a REM parasomnia would more likely happen late. And also you need to remember that post-ictal behavior can mimic an arousal disorder. If all you get is somebody's walking around confused and what happened before wasn't observed, you don't know if there was a seizure that then resulted in that or if they awoke and then had a parasomnia. So now a little bit about REM parasomnias. So the ones I'm going to just mention, nightmare disorder, we call it a disorder when it's actually causing a problem. Everybody's had nightmares. That happens. For most people, it's not really disruptive, but if it's repetitive and it's causing, it often will cause insomnia. It's so disturbing that then the patient wakes up and can't get back to sleep. You sometimes actually need to treat it. There are parasomnias associated with narcolepsy, which I'll talk about, and REM behavior disorder. So what are the possible symptoms with narcolepsy? Narcolepsy is really 5 possible symptoms, all of which have to do with a disconnect between being asleep and being awake. So the first that you must have in both narcolepsy 1 and 2 is excessive daytime sleepiness. You may or may not also have hypnic hallucinations. So these are dream images that either occur as you're falling asleep or after you've woken up and you still see something. And so this is a REM phenomenon. You're dreaming, but you're actually partly awake. And the example I use, there was a time when I was very sleep deprived. It was because of a puppy. I don't know if any of you have ever had a puppy, but I think in the short term it can be just as difficult as having a child. But a long day with the puppy, put the puppy in the crate, get into bed, start falling asleep, and I see the puppy sitting on the bed. I was like, this is so cool, I had a hypnic hallucination. But, so it can occur sporadically, but it also can occur in narcolepsy. Sleep paralysis is the paralysis I was describing that either occurs as you're falling asleep or you've woken up and you can't move. Now that can obviously be very disturbing to people, so they'll come in and describe that, and that can be part of narcolepsy. I'm going to talk a bit about cataplexy. Cataplexy is sudden weakness that occurs while you're awake. It's usually induced by something. Most classically, it's laughter, but it can be any emotion or it can be fright. And I'll show you an example of that. And the last thing is, even though these people fall asleep very easily during the day, their sleep at night is often very fragmented. So there's a disconnect in the switch. They're falling asleep very easily during the day, but they're also waking up a lot during the night. Now, it's important to remember that all of these can occur sporadically in the general population. So just because you have sleep paralysis, by no means do you have narcolepsy. It's just part of the symptoms that can occur with that, but it can happen for other reasons. So sleep paralysis, as I said, can be isolated. And the numbers are that up to 50% of normal people will have experienced this at some point. I won't ask for a poll of who has, but it can happen. Patients can usually move their eyes during it. It lasts a relatively short time, and for reasons that are not clear, if somebody touches them, it usually brings them right out of it. The most common place you see it is with sleep restriction or sleep deprivation from some other cause, as with many of these parasomnias. And then I'll show you an example of cataplexy. As I said, it's usually precipitated by emotion or laughter, or it can happen with startle. And unlike fainting or an atonic seizure, it's usually a slow onset weakening of muscles followed by collapse. It's just not running. Oh no. This one's not working. Well, this is it's actually an example in a narcoleptic dog, where what you see is, the little dots on the thing there are actually dog treats. So that's very exciting to a dog, and when she comes out, sees the dog treat, you see her just sort of start collapsing. Not like an atonic seizure, but a slow collapse of the muscles. And that's what people describe too. It's usually, they don't go flat on the floor, they usually don't hurt themselves, but they will start feeling weaker. They can usually get to a chair or to a safe place, and then it doesn't last that long. They usually retain awareness, but this can also be quite disruptive, as you can imagine. It's weird, it looks like it's running, but it's not. Oh wait, now it is. There she is. Okay, I don't know why it wasn't running before. So yeah, she feels, it's like, this is what you'll hear from people. They feel it coming on, they sit down, they wait for it to pass. All right, let's not think about the treat, let's not think about the treat. I know what's gonna happen here. Oh wait, there's another one. Oh. And the dogs do have narcolepsy and they are used in research, so that's how we know about these things. But it's pretty. I don't have a video of a person having a narcoleptic attack, but that's what they describe. Okay, so how do you treat it? The main problem with most narcolepsy patients is actually the excessive daytime sleepiness. So there are a number of medications available for this. Most people with narcolepsy need them. The first line is now generally modafinil or armodafinil. There's a newer drug, solriamfetol. These are preferred because they have less abuse potential and they have fewer side effects than the traditional treatments, which are the amphetamines. There are a couple other classes of medicines that can be used. If the main problem is, or if they also have cataplexy, the drugs above, the stimulants, won't generally do much for that, so they may need additional treatment with antidepressants or SSRIs. And there are a couple of drugs, sodium oxybates. There are now 3 types of sodium oxybates. Xyrem, the low sodium is Xywav, and the long-acting is Lumryz. These are very different. They're taken at night to deepen sleep. They put people into a very deep sleep and are approved for both the sleepiness and for cataplexy. But they're more cumbersome to use and there's more likely to be side effects. So I don't use them first line. I usually try the stimulants first. And there's another drug called pitolisant, which is actually not a controlled substance, but is approved for both sleepiness and excessive and cataplexy. And then I think this is the last poll, what you think this person has. So this is a 48-year-old man. He has obstructive sleep apnea, so conveniently he's wearing a mask during this. He had new onset of episodes arising from bed and striking his bed partner, which were accompanied by a dream image. And his dreams were actually rather stereotyped. It's disturbing if, when I heard about this case, Dr. DeWolf told me what his dreams were, and you can probably imagine what's happening, but he was actually having dreams of strangling someone, and then looking for something, and now we stab her. So, obviously associated with a dream image. So this one hopefully will be clearer than some of the other ones. That is the key. Now, you don't always have that full history. You might just get the history that they're striking out in their sleep and the patient doesn't remember a dream. So it can be more difficult than that, but you can usually get that diagnosis by history. So how do you treat it? Well, obviously you all know very well it's associated with neurodegenerative diseases and can precede symptoms of neurodegenerative disease. This is something that we always have to talk to patients about, because if you don't, they will find out and they will panic if they haven't already. So you have to acknowledge that there is an association, make sure that they don't have any symptoms at that time, and then you follow them over time. This REM behavior disorder is more common in men and consists, as I mentioned earlier, of lack of the normal atonia that happens during REM sleep. So you literally act out your dreams. Now, the important thing, especially with relationship to the neurodegenerative condition is you have to make sure it's not from another cause. Probably the most panicked patient I ever saw, I had a colleague call me, you have to see this guy right away. His wife's a physician, he's acting out his dreams, he's convinced he's got Parkinson's disease. So we get him in the lab, and I talked to him. A, he's sleeping like 4 hours a night, I think he was in finance or something. B, he was drinking too much. And C, we found out he had untreated obstructive sleep apnea. We fixed those, and everything stopped. So he doesn't have idiopathic REM behavior disorder, and he doesn't have an increased risk of neurodegenerative diseases. How do you treat it if they do have REM behavior disorder? Safety is first. You have to make sure that these patients are going to be flailing around in their bed. Sometimes the bed partner needs to sleep separately, or you have to arrange pillows, something between them so the bed partner doesn't get injured. Remove sharp objects. Put something soft on the floor in case they fall out of bed. Sometimes you need bed rails. All those things you got to think about. If they need treatment, clonazepam is usually effective, but we often start with melatonin because it's more benign, and sometimes it does help. As I mentioned, you have to look for other conditions. So I always do polysomnography in these people. One, to document what their REM sleep looks like, but mainly to make sure there's not something else going on, even though you can get a pretty good idea by history. There are some other treatments, but they're basically anecdotal. So now I'm going to go back to the first case that I mentioned, that 26-year-old man who had the nocturnal confusion, and the differential was pretty broad. So he got an MRI and a polysomnogram and a routine EEG, which were normal, which is okay. But then he had an ambulatory EEG, which you can, I don't know, I apologize, it's rather small, but you can see a pretty dramatic left temporal spike if you look at that a little bit to the left there. And we put him on levetiracetam and everything stopped. So, the history was, it could have been a couple of things. It could have been sleepwalking, somnambulism, but in this case, it was nocturnal seizures. And, I mentioned at the beginning he was a firefighter, so I was horrified about this. He's sleeping. And, I had to talk to him for a long time, but he never had anything while he was awake. He told me what would happen, like if he woke up confused, somebody else, I didn't feel like he was at risk, but anyway, everything stopped once we put him on anticonvulsants. So just by way of summary, in terms of parasomnias, you can usually get a very good idea by history what is going on, and if the treatment pans out, you don't necessarily have to do anything different. Many of these are benign, and most respond to treatment if they need it, but when the diagnosis is in doubt, or you think it's one thing, you think it's seizures and they're not responding, then you think about further workup, which is usually polysomnography or video EEG. So that will confirm the diagnosis, but also look for additional disorders. So hopefully Dr. Holmes' presentation is going to work now, and hopefully this wasn't too disturbing that it was out of order. And we're going to take questions at the end, right?
Yes, questions.
Okay.